Hey guys, I'm Nancy for those of you who don't know me. I'm very excited to be one of your moderators today, and we'll start by introducing our two faculty members from the AdventHealth Critical Care Fellowship Program. I have the pleasure of introducing Dr. Robert Cambridge. I don't know if I mentioned before, but he's the program director of our critical care program here in AdventHealth Orlando. He was an emergency medicine physician for the Air Force and faculty at the Air Force EM residency. He did his critical care fellowship training in Washington University in St. Louis, and then he was a faculty member in the multi-trauma ICU at Baltimore Shock Trauma. After finishing with the military, he came to Orlando where he started the critical care fellowship program. He has served as the state chapter president for the Society of Critical Care Medicine and currently is the past president of the board of directors. Thank you very much for joining us today, Dr. Bob.
Hi everyone, it's Hamza. For those who don't know me, I'm a third-year chief resident at University of Central Florida in Gainesville. I'm very pleased to be with you here as a moderator of this event. I'm very excited to kind of start this fellowship series about the most competitive 4 fellowships, starting with cardiology, then pancreas, and then we're going to be doing other episodes, one on gastroenterology and another one on hemato-oncology. Today we have very distinguished guests. Nancy already introduced Dr. Bob Cambridge, and I'm going to be introducing Dr. Martin Cearras. Dr. Cearras, he's the Associate Program Director at the Critical Care Program in AdventHealth Orlando, and he did his medical school in Argentina, specifically at the Favaloro University in Buenos Aires. And then he did his residency and pulmonary and critical care fellowship at the University of Miami. Dr. Cearras is currently the critical care medical director of the liver and multi-system intensive care unit at AdventHealth Orlando. I'm very pleased to have you, Dr. Cearras, with us today.
We're very happy to be here.
All right, so to get us started, once we have introduced ourselves, so we're going to go kind of on the whole process of choosing to be a critical care fellow to becoming a critical care attending. So let's start at the beginning. The first question that I want to ask you is, and this is probably more oriented to PGY1s and PGY2s. When you do a critical care rotation and you're still unsure if you even want to do this for yourself as a subspecialty, what things do you think a resident should be looking for in their experience through the rotation to determine if this is the right fit for them?
Martina, I'm going to let you take that one. So as Dr. Zerpa mentioned, I'm coming from an emergency medicine background. And so my reasons for going into critical care might be very different than everybody else's. So I'm going to defer to Martine for this.
Okay, so I think what I would look for is the difference that critical care has with everything else. So it's a very procedurally oriented specialty. So if you're good with your hands, if you are interested in doing procedures, that's for you. You also have to be decisive. You need to be able to make quick decisions with high stakes and, stick to your plan. And I think those are probably the 2 main characteristics. I can tell you, when I was in training, I realized after doing a lot of clinic and inpatient that was way too slow for me. I was just bored. I'm like, I need a little bit more excitement in my life. Clinic, the hours would not go by. It was like really painful for me. So critical care has that constant excitement and things going on and new things. And also, if you've been diagnosed with ADHD, you probably fit with us very well. I don't know if that answered your question or I forgot something.
Yeah, I mean, there is a bit of personality self-selection, I'll say, amongst internal medicine trained people. critical care more than anything else, if you're the kind of person who, when the alarms go off, you run toward them, that's key. I will see people, the alarms go off and they run to the computer. Critical care, truth is at the bedside, and so that's where the intensivist is needed most. So there is definitely a personality component.
Do you feel like the personality component would have anything to do with people who are emergency trained versus internal medicine trained? And the reason why I ask is I don't know if there's a higher proportion of emergency medicine doctors who apply to critical care versus internal medicine trained.
No, and actually there's a lot of, so emergency medicine trained residents are eligible to enter the IM critical care match. And in fact, they're eligible to enter the critical care match. They are not eligible to enter the POM crit match. With that said, just as there's a personality component of internal medicine people who do well in critical care, there's very much a personality component for emergency medicine people. The people who, this isn't necessarily relevant for you all, but for emergency medicine people, the people who sit there at the end of their shift and go, I wonder what happened to that person, and look them up over and over again. Those are the ones that do well. So there's a personality component on both from both pools of applicants.
I see. And now kind of referring back to something that Dr. Cearras just said, and I'm going to ask my question from my own personal experience. I have been very fortunate to work with you both as my attendings. And do you feel like someone who is initially not very procedure inclined, is that a limitation to do critical care? Or is that something that should deter people from applying to critical care? Because I know that happens to some of us. And then what is your take on it? I think I know the answer, but I want the audience to know.
There's this interesting phenomenon kind of early on in the fellowship training process. The people who are EM trained come in much more procedurally proficient than the internal medicine people. And the internal medicine people come in much more, Martina, I'm not quite sure how to say this, they think about the problem differently. They think more deeply through the differential and stuff. Honestly, by month 4, month 5, you can't tell the difference between the two trainings.
I echo what Bob said, and I can tell you, depending on where you train, your exposure to procedures will be different. And our trainees, even within the same specialty, the ones coming from ED or the ones coming from internal medicine, are very different regarding their experience with the different procedures. And we have been able to train all of our fellows to be safe, to be efficient, to be quick, and to do the procedures to perform them very well. So, and I can tell you, one of the benefits in critical care too is that we all come from different backgrounds, and we also have surgeons, and we have people like Bob, and I still learn tricks from them even now. I mean, we're always learning new ways of doing things, more efficient ways of doing things, and so I think it's a lifelong thing. And if you're not really succeeding at your procedures, it's because you have not done enough, and we can fix that.
It's a practice.
Now, with that said, because this is not just an advertisement for our program. If you come from an internal medicine program that does not have a lot of procedural exposure, and you self-identify that is a concern, then during the interview process, that's something you're going to want to ask the program about. So if you go into a POM crit program and you go to a place where anesthesia does all the intubations in the ER, and believe me, those places exist, and you go to a place where general surgery comes and places all the dialysis lines, then yes, it's going to be harder to get that procedural comfort than if you go to a place where critical care or POM crit does everything. So you're going to just want to, during the interview process, drill down, in programs and ask them specifically, who does the intubations, who's responsible for procedures on the floor during codes. If I don't feel comfortable, are there opportunities to go to the operating room and do airways there until I do feel comfortable? But that's, to some extent, that's a self-reflection thing, I think. But most programs should have a process in place to get you well trained for the procedures. Critical care a few years back did away with the procedural requirements in terms of specific numbers that you need for different procedures. So nowadays, the program director at the end just has to attest that you are competent in doing central lines, intubations, bronchs, even swans are on that list, but there's no numbers associated with them. So you can get that level, the level of competency that ABIM requires just by doing simulation, but you may not necessarily want to when you go on and practice yourself.
Okay, thank you very much to both. Something that I will add just as a reflection for whoever is here that is a PGY1 or PGY2. For me, before deciding to apply to critical care, kind of what Dr. Cearras said about the clinic hours wouldn't go by. I would also encourage residents to look for that feeling of, even though the hours are tough, you're kind of not tired, you're excited about what you're doing, you look forward to coming back. For whatever reason it might be the procedures, it might be something else, but something just to throw it out there. And let's say that now the person has fully decided that they're going to apply to critical care or to POMCRIT. What advice would you give them? What does a resident need to do to be a strong applicant, to be considered, to be interviewed?
I think we look at a little bit of everything. We do happen to have a very algorithmic way of looking at things. Bob gives everybody like points based on scores and things that they've done. So I think each program is a little bit different. Something that most people ask me when they're considering doing critical care, they're like, can I do more rotations in critical care? Should I do this? Should I do that? And I think with Bob, we disagree a little bit on this, and it's okay. I mean, he likes sending them to do more critical care. I like telling them, do something else. You're going to do enough critical care where you're going to be trained. That doesn't really add a whole lot, but you need to show interest. You need to have enough exposure that we know that you know and you like critical care. But just doing all critical care, I don't think it helps you. Add some ID, add some nephrology, add something else that would enrich you.
One of the interesting challenges that we've had for the past couple of years so we come from a pure critical care program. Figuring out who is actually interested in pure critical care versus pulmonary critical care, because for us, ranking somebody who is primarily interested in pulmonary critical care means that I've not interviewed somebody else who has more of an interest in critical care. Now, that's a program problem. That's not an issue for the applicants. You all should be applying where you want to go. But that's, as Dr. Cearras mentioned, kind of expressing that interest and being honest about it. If you go to a critical care program and say, oh, no, I'm only interested in critical care, and then later on when we get the match list, I look at it and I go like, well, you matched in pulmonary critical care. Oh, all right, and doesn't do anything other than just me going, that's odd, but it's just something to, just be honest with the programs you're applying to. Yes, I'm interested in critical care, or hey, I'm interested in critical care, but I'm really more interested in pulmonary critical care. So, you might be a backup program for us. It won't hurt my feelings. It just lets me know, gives me an idea. And if you tell a pure critical care program that you're interested in pulmonary critical care, it doesn't actually change where you are ranked on the list, because I'm still going to rank you where I want you in the hopes that you don't match at one of those pulmonary places. So that, there's no gaming of the system there either. But along those lines, there is a bit of a shift starting, that's starting in these fields. That's probably going to take, another decade or two to fully shake out. You'll know if you wanted to do critical care, the primary track was through pulmonary and critical care together. And nowadays, the number of jobs that you can do pulmonary and critical care and spend equal time in both is getting smaller and smaller and smaller. And it is really hard to have a foot in both worlds. Do those jobs exist? Absolutely. And, if you, again, self-assess and say, I want to spend half of my time in the ICU and half of my time in the pulmonary clinic, absolutely go for it. But if you self-assess and say critical care is what I want to do, and do just a straight critical care program. For one, you're going to spend more time in the ICU during a critical care program than you will at a pulm critical care program. I would argue that you will be trained better as a critical care doctor at a pure program because I have more time to send you through cardiac units, ECMO units, surgical units, neuro units, and other areas that will make you a more well-rounded intensivist. And as time goes on and bigger centers, and even now spreading out to smaller centers, your intensivists spend all of their time in the ICU. They don't do clinic. And if you've spent 1 year, 5 years, 10 years, 20 years out of the clinic, the notion that you can use pulmonary as a fallback when you decide to retire is not realistic. I have been out of the emergency department for a couple years now. I used to do a shift here and there and stuff. It has been a few years, and now I am full-time critical care. And if I try to go back to the ER, I am not anywhere near as good as the pure ER docs. The people who come into the ER don't get as good of emergency medicine mindset from me as they would from somebody else. So it is not that I can look back at that as a field to fall back on in the future. And I think we're still in that time when people can do pulm and crit and decide which one they want. But the time will come years down the road where pulmonary programs will become more predominant, critical care will be more predominant, and combined programs are really just going to be for people who want to do high-level academic research.
I'm gonna have to agree with you there, Bob. Although one thing that I think a little bit different is, I did do the two things together in the past, and then after a lot of soul searching, I decided to let go of my pulmonary practice. But I tried to get some of those skills back just to have them because I don't want to lose them, and it was kind of like riding a bike. Yes, the clinic might not be the same, but you can still probably do like inpatient pulmonary, or I could do inpatient pulmonary if I wanted to. I could probably go back to the clinic. I'll be rusty at first. I agree with you, it's not the same, but I'll probably be able to get it back, especially since I've been keeping my boards. But regarding the lifestyle too, if you want to go into pulmonary critical care, the reason why I started doing just critical care alone is because I was getting paid the same to work every single week versus to do shift work. And when I was working every single week, I was still doing all those 12-hour shifts. So all of a sudden, I'm like, if I drop pulmonary, I only work 14 shifts a month. So that is a difference in lifestyle that you're gonna have. But I don't know if that was a question for later.
It's okay. We want it to be as organic as possible, but I do want to ask, because we wanted to talk about the difference, especially because Dr. Cearras is pump crit trained and Dr. Bob is critical care trained. If in terms of applying, maybe you can give like a pearl as to how does a resident decide that they want to do pump crit? Maybe are they more patient inclined and that's why they want to do pump crit? And then is the application process different? Meaning, is pump crit more competitive than just crit? Do you have to be a stronger applicant?
So if you look at the matching lists, so every year, after the match occurs, NRMP puts out a lot of data about the applicants and the field and how competitive it was. And critical care versus pulm critical care, pulm crit still continues to be more competitive. Critical care, on average, I think it's about 1.7 to 1.8 applicants for every spot. versus palm crit, which I think is 1.9 to 2 or something. It's still, palm crit is still kind of like right under cardiology and GI. Palm crit's right there. But critical care for the past few years, so pure critical care wasn't in the match until just a couple of years ago. So we don't have data prior to that. It was all outside the match. But critical care each year has continued to increase the competitiveness in terms of the number of applicants relative to the number of spots. And that is despite the fact that every year more and more programs are opening. So the number of spots the number of applicants of fellow spots has increased every year since the match started for critical care. Is that trend going to continue? Probably. Yeah. When will that point come when critical care passes palm crit? I'm not sure. That I expect that, because that's kind of almost a zeitgeist change. I think that's going to take years and years and years.
All right. So Hamza will go ahead and I will transition to interview process and fellowship life.
Sounds perfect. So that's a very enlightening discussion. Actually, I'm applying to palm crit only, and Nancy is probably applying to crit care only. And we have people from both fields. We have Dr. Cambridge who did pure crit care, EM crit, and Dr. Cearras who did palm crit. So it's good to have both opinions. Now, let's imagine that somebody submitted his fellowship application to either palm crit or critical care, and then he is waiting for his interviews, and he did receive some interviews, and he's trying to prepare for those interviews. In terms of preparing for fellowship interviews, what tips can you share with us to have a successful interview that will allow you to get ranked higher? So what are the tips that you can share on that?
I think I would say be honest, be yourself. People sometimes come with all these practice speeches that you can tell and they sound like really fake, and you're like, be ready to answer questions. I mean, think about yourself, know yourself, and be able to answer about what you're really interested in, what drew you to critical care, have an example of something that you find memorable, in the ICU as you were rotating. I think, and we look at all the academic stuff, but one of the things that's very important for us is, are you going to fit with our team members, with our fellows, with our attendings? And part of that, we get the input from the fellows when they meet with the applicants and they ask them questions, would this be someone you want to work with? Do you think that you're going to get along with? Because that makes a big difference. If you're going to spend this much time with people, you got to make sure that you have a group that you like.
Mm-hmm.
Am I missing anything, Bob, that you want to add?
Yeah, I say don't try to game the system. Just be yourself. As Dr. Sierra said, you can tell almost immediately who has the pre-prepared. I had one time as somebody was reading and they were kind of looking down below the camera and they were talking, and then there's a moment where they kind of moved and and then they flipped the 3x5 cards, and I was like, just show me the card. I can read it faster than you can say it. But yeah, it is as much, by the time you get to the interview, you're all doctors. You've all trained in internal medicine. You all have board scores. You all have research. You all have all of that stuff. By the time you get the interview, now is the point where it is as much of an interview for you as it is for us. We are trying to sell you on the program, and you are trying to sell us on you. But it's a match, and and not talking about the NRMP match, but it's a personality match, And so that's just where, if you just be yourself, that's where you get the idea, we get the sense of, okay, who is this person? Especially in the era of Zoom interviews. It is so much harder now that we can't see you for a couple hours and kind of, walk through the halls and talk with you and stuff, it's so artificial. So the more of yourself that you can get through in that 15 minutes that you have with each person will give us an idea of, is this just the kind of person we want here? And you should be getting that same thing. If you get off the phone after a Zoom call and you go, those people were jerks, don't rank them. Like it's, or, if you something about that interaction ought to resonate with you because you're going to be stuck with these people for 2 years, 3 years, whatever. You don't want to be miserable. So I think
Yeah. Go ahead.
I was going to say, I think maybe another or a twist on your question is, are there things you can do before you get the interview? Because the things that we look for pre-interview are going to be very different. And that's where, okay, by the time you're a third year, the dice are already rolled on that one. But if you're a first year and a second year, the things you can do just to get that interview, research in critical care, something on your resume that says, I am interested in this field and I'm not just picking it because I need to do something other than hospitalist. Show dedication to the field. The letters that you get from your critical care, pulmonary critical care docs really ought to speak to you and not just sound like a form letter. I get so many of these that we read through, and it's interesting because I'll even I can go back and look at letters from the year before and from the same program and go, well, wait a minute, all they did was change the name, But if the letter actually tells me something about you, then I go, okay, this person knows this applicant and really wants them to succeed. All right, that's somebody who has put the time in to get that interest, to show that interest. Take part in your state and local organizations. Be part of, either the critical care societies, the pulmonary societies. Be part of. I don't know if ACP has, chapter, sub chapters or committees or whatever. Those sorts of things that you can put on your application, catch our eye and go, all right, this person really is interested. The board scores. Everybody has board scores. That's doesn't make a big change.
Mm-hmm.
Yeah, have something that stands out. And then also, sometimes people are mean to our program coordinator or something like that. Just be nice and respectful to everybody that you interact with in the program, That's also just common sense.
Sounds good. So from the discussion, I kind of remembered one of the books that I read recently. His name is The Unspoken Rules, Secrets to Starting Your Career Off Right. And in that book, he kind of explains in detail how to build your career. And he focuses on the 3 C's: compatibility, competence, and commitment. The way I kind of look at it is you can explain your competence and commitment in probably your CV and your personal statement. And then when it comes to the interview, it's probably a compatibility kind of game. So would you agree that the interview is just a compatibility game? So you have to put aside showing off. For example, a lot of people like to brag about what they did or talk about what they accomplished during their residency or all that stuff. Would you kind of consider that as an arrogant applicant who talks a lot about his accomplishments during an interview? And would you, let's rephrase the question in a better way. Would you say compatibility is the main focus when it comes to the interview, or you also would like to chat about competence and commitment as well?
No, that's always important, and that's part of the be yourself thing. But like Bob said, once we chose you for the interview, we think that you would function well. We just want to look for any red flags. Are you gonna work well with us? Those are the main things. But yeah, it's always important, and you show the commitment, like you said. You show your competency basically by the things you have done already and put in your CV. If you've done something really cool in your training, it's not bragging to talk about it. Actually, you want to point it out. It's just don't be that guy. Don't just make everything about that one thing. And if it's something that everybody else has done, don't just overinflate the value of that.
Mm-hmm. Mm-hmm.
Yeah.
What do you think?
I look like somebody started up a vacuum around the corner, but oh well. So if you go, especially if you interview at a place where you have multiple interviews with different faculty, you don't have to repeat yourself. You don't need to tell each and every one of them the same story, the same bit about yourself. Yes, we're gonna talk amongst ourselves. So if you have something important about yourself you want to bring out, just pick one person to tell it to, and then everybody else, it just becomes kind of a talk about who you are. I do agree that yes, I think that's the interview really is sort of like a compatibility match.
Sounds perfect. The other question I would like to ask is how to prepare for your interview, in terms how to prepare for every specific interview you get. Any thoughts on that?
I don't think there's much preparation. You've done your preparation throughout your early career, I think. Dress professionally, show your best self, don't be late. Those are the important things. And I don't know if you have any other tip.
Test your computer and your microphone ahead of time. It's so much. I don't know how it is from the applicant side, but I will say from the program side, I cannot stand Zoom interviews. I would be so much happier if we could go back to in person. But I recognize that there is a definite cost and time expense to the applicant that is ameliorated by having Zoom things. But oh my goodness, it is so much harder for us to kind of get a sense of that compatibility and stuff. So yeah, really, it's all the things that you would do before some other Zoom conference.
Yeah, and that reminds me. Sometimes when you're on Zoom, you actually could present worse than you would in person, or the other way around. So that could be a handicap, or it could be a benefit to you. But we have had people that, for example, interviewed with us, and they were very interested, and then came for an in-person interview afterwards. And that gave them a lot of points because then we got to see them. We could evaluate that compatibility more. You can see the commitment. So if you're really interested in a program, you could consider not going to all of them, but just the one that you're interested in. Just show up for like an in-person interview if you can afterwards. We have like a second look that you can do. For example, I'm sure a lot of other programs are doing similar things.
Sounds perfect. That actually was the next question in mind. We did a study actually on that specific thing, in-person versus virtual interviews, and we published that in ATS School of Medicine for Palmcred specifically. And we found that applicants actually match at lower options on their rank list after the virtual interview format because of the higher number of applications to each program, and also because you cannot really show your compatibility sometimes on Zoom interview as you can demonstrate it in person. So I will have to agree with Dr. Cambridge actually on that point. The other question is there is multiple common interview questions that get asked, and one of the questions that were kind of brought up in the cardiology episode yesterday, and it gets asked frequently in Palmcred fellowship match interviews, which is, what are your weaknesses? I'm not sure if that's a question you ask yourselves, but if you have any thoughts on how to address such a question, it would be much appreciated.
I'm not sure. I don't think I've asked that one before. Well, probably should add it to the list. Generally, that questions like that fall into the self-reflection category. Programs are looking for, can you assess yourself? I ask it in a different way, because usually when you ask, what are your weaknesses, people will say, oh, I stay too late, and I care too much, and I want to do this too much. Something ends up being self-serving. But the idea is just that self-reflection. And again, with any question like that, I think really the only wrong answer is something that is transparently false. If you say, look, my biggest weakness, I've got a palsy, and every time I try to do a central line, I just keep like stabbing the person in the neck. Okay, I know what I'm working with now, and you recognize that as a problem. How have you tried to overcome that? Well, I've tried to overcome that by now I wear a hand brace, and when I place the line, it goes fine. Goes fine. Great. You've assessed the problem. You've figured out an issue. I know that you can self-reflect on things, and we can work with this. Versus you give me some answer that's flippant and doesn't really show self-introspection. That's going to go over less well.
Mhm.
Yeah, and you can talk about something that you really are working on. I mean, I'm not super organized. I'm working on that because I know I'm gonna have to have checklists. So my mentor gave me this tool. You can talk about something that you're working on too. I think you will get asked that question. Bob might be the only person that doesn't ask it.
There'll always be some kind of question doing self-reflection. It may not necessarily be what's your greatest weakness. You know, maybe it's give me a situation and that you don't think you handled quite as well as you wished you had later. Something again where you have to be critical of yourself. We all have to do that. That's part of being in medicine. And again, like, if you can't do that, or if you kind of sidestep that question, I think that's more of a red flag than whatever possible answer you give. Yeah.
Sounds perfect. Moving on to the next section of the webinar, which is after matching into your fellowship of choice. Let's talk about critical care specifically. What things you can do during the 6 months that are left of your residency to prepare for your fellowship? Is that something you need to be concerned about, or you just need to study for your boards?
Now, this is where I answer that question with Cearras' answer. After you've matched, stay out of the ICU. Go do anything else. Now is the time to kind of make yourself as well-rounded as possible. Do that, endocrinology elective, spend some time at the rheumatology clinic or whatever. Okay, now you secured it. You're going to have years to study, to be immersed in pulmonary critical care. I know people who ask for reading lists, who ask for, I know, like, go hang out at the beach, work on your tan, whatever. Just you've matched. It's done. You're gonna start. It's what I tell applicants when they come for critical care interviews is critical care is the most time intensive rotation of residency continued for 2 years. So enjoy the time you have at the end. Certainly if there's a procedure in the unit or something, and you have the opportunity to do it, yeah, don't give it away. But you also don't have to elbow your fellow residents out of the way in order to do procedures that otherwise wouldn't have been yours just because you're going to this field.
That's good.
Yeah, and remember, and that's why I always tell people do other rotations. Critical care touches every single other specialty. You're gonna see the sickest patients of each single specialty. So get familiar with everything else. You need to know a lot of medicine to do critical care.
Sounds perfect. And my last question before going back to Nancy here is how to be a good fellow. What do you consider a good fellow in your program?
Be flexible.
Mm-hmm.
Any program. I mean, ours is still. It's funny. I still think of our program as new, even though we've graduated a couple years worth of people now. Three, but every program is always going to be adapting. Hopefully, and so the program that you signed up for, by the time you start, they may have changed some things. And that's, it's also a very valid question to ask programs during the interview process. Are there major program changes that you foresee in the next year? But maybe you were really, really excited about their interventional pulmonary rotation, but that interventional pulmonologist is about to take a job somewhere else. So you show up and that person's not there and that rotation's gone. Be flexible. All right, that program, that rotation's not there, or things have changed, or the hours are different. It's still within the bounds of ACGME rules. How can I still get a good learning experience out of this? What is the program going to do to fill whatever gaps that just occurred? Or maybe something that's new, or some new expectation sounds terrible at first, but after you've done it for a while, you realize like, oh, there is a really good reason for this. Most programs are not malignant. Program directors, stuff, we all have everybody's best interest at heart. My goal is to make the next generation of well-rounded intensivists who can walk into any hospital and succeed. So I'm not going to do things, during training that are going to make life miserable for you, unless there's a really, really good reason for it. And if there is, don't worry, we're going to be sharing the pain as well. But that flexibility, I think, is essential, especially if you're going to a new program, meaning not the place you trained at for residency. Because for the first couple months, it's all new to you. Everybody else is going to be used to how the place runs and works. And so you have to have that flexibility of like, all right, this isn't how it was during residency, but I'm not going to get worked up about it. I'm just going to figure out how this new place works. Roll on with it.
Sounds good.
Yeah, and I'm gonna say, the training is gonna be hard. Like they say in the military, embrace the suck. It's not gonna be easy. If it's easy, you're doing something wrong and you're not learning. So it's gonna be hard. You're gonna put the time. It's an investment in your future, and you're gonna come out a lot better for it. And also, be humble. Remember that even if you think that the person that's teaching you might not be the brightest, the smartest, whatever, everybody has something to teach you. Even your respiratory therapist, your nurses, they've been doing this for a very long time. They can identify patterns. You're working on your pattern recognition. So, be humble, be nice, and try to absorb as much as you can. And you can always push your attendants, ask them why. Why are they making the decision they're making? Think or try to get a picture of their thinking process. Learn how different people think. Get exposed to different people, and then learn what works for you. There's not one way of doing things. Okay, there's many different ways of reaching the same outcome that might not be wrong. So give it a chance.
And there's a big growth step that happens between residency and fellowship. And for some, it happens, the first month or two, and for some, it happens 4 or 5 months down the road. But there is a difference between a resident and a fellow. I tell early fellows, if you weren't here training, you would be an attending right now, and you would be my colleague. So there's still that colleague mentality with the fellows, and there should be wherever you go. And there should be that sort of like extra level of ownership, I think, that fellows should take on of, hey, this is my patient, more so than I'm taking care of this for my attending, which is kind of how residents tend to approach it. This is my patient now. I'm going to make all the decisions for it, and all the decisions are going to fall on me. Okay, maybe they're actually falling on my attending and standing behind me, but and we can always tell when that kind of change in mentality happens. And that is the moment where I go, all right, now you're a fellow.
Yeah, and you should look for that in a program. They should let you make your own decisions and be there in the back to support you. And step in if you're doing something wrong. But again, they should give you a little bit of freedom to do things in a way that makes sense, but it's a little bit of your way.
The residents have had to, the residents here and the fellows here have heard it. I told them, there is very little that you can do to a patient that I can't undo. So don't be worried about making decisions. That's not
I,
true.
you can break the patients and I might not be able to fix them.
All right, thank you very much for this answer. Now we can go back with Nancy.
I love that answer because I have heard that answer myself. It's like there's very little you can do, just go at it that I cannot fix. All right, so for the last portion of our webinar would be life after fellowship. You know, what is the typical lifestyle of a critical care attending? Pathways or choices for different work hours, do all attendings do nights, stuff like that. So what is like your most common, I guess, schedule for an ICU attending?
I would say you can find any kind of different job you want. A lot of them will be 7 on, 7 off. There's still like 7 days, and then the next shift stretch will be 7 nights. I think we're going more into having nocturnist, kind of like what the hospitals do. So places are tending to hire them more. You get a little bit of an extra bonus for doing nights, so you do less shifts. Some people prefer to do that, not me. If you do pulmonary critical care, you will work a lot more because basically the weeks that you're not doing critical care, you're going to be doing either clinic or inpatient consults. So that will change your lifestyle. But most places you end up having a shift work model. You will work very hard for a week. We are working about 84 hours visit with the, yes, it's a 12-hour shifts. And then the next week you have off and you can, have hobbies. I would recommend you have hobbies. You don't just do medicine. That will just suck your whole life. Just have other things that you're interested in and spend time with your family.
For the most part, there is no call. That's, I think, one of the best things about critical care is that it's shift work. Now, there are jobs where you're on 12 hours at the hospital and then you're on call for 12 hours overnight. Those tend to be your much smaller centers. Your critical access hospitals, smaller community centers, but that continues to get less and less. So for the most part, it is shift work, and that's a big change for a lot of people coming from internal medicine. Emergency medicine docs, that's what we've been doing. So that's one of the things I can always tell, like an internal medicine fellow, for emergency medicine trained fellow from an internal medicine trained fellow, is how quick their sign out is. But like the EM people are like, all right, everybody's alive, nobody's dying, their blood's good, I'll see you in the morning, bye. And the internal medicine people are spending 20 minutes doing sign out, and I'm standing there going like, I just want to go home. But you get used to it. So obviously the lifestyle is going to depend on the facility you're at. As Dr. Cearras mentioned, yes, if you do a split model critical care pulmonary, again, a lot of it's going to depend on how it is, how your hospital staffs, but in general, the critical care portion, shift work, when you're on, you're on, when you're off, nobody's calling you. When you're on the pulmonary time, you may have pulmonary call, pulmonary coverage, clinic, whatever requirements are in your contract for that. So that can be variable as well.
Well,
Yeah,
thank you very
and
much.
if you're thinking about going into both, if you think about going into both, you can always say at the end, hey, I just focus on critical care if I want to, if that's your main goal. So that gives you a little bit more flexibility. And also, how does your life look like inside the hospital? You can do some tracks now in critical care. We have people that mostly do ECMO. We have people that focus on neurocritical care. We have people that do cardiovascular ICU in other campuses. So you can be kind of like a general intensivist like Bob and I, or you can end up specializing and doing just one thing.
Well, thank you very much. I think I love first of all, thank you because both your answers are usually very genuine. And I think it speaks to kind of the topic that we're talking about today for applicants, for future applicants, for fellows, the most important thing is just be yourself, right? And have fun doing it, and just find something that you love enough to do it a whole lot. I think that kind of well rounds all the transition between being a PYY and thinking about it, applying, interviewing, graduating. And we actually have a few minutes, so if the people in the audience want to go ahead and ask questions to either Dr. Cearras, Dr. Bob, or both, please go ahead.
Nancy, I just want to say over here, before I go to we go to Dr. Shafiq's question, Dr. Hart was mentioning what's the recommendation between doing critical care versus pulmonary treatment in terms of a long-term career. I think this thing covered, throughout the webinar. It was more of an early question, but in case anybody has any other.
Yeah, I think that's just it's assessing how do you see your job 10 years after training. If you see yourself primarily working in the ICU, just do critical care. If you see yourself primarily working in the clinic or on floor rotations, just do pulmonary. If you see yourself at an academic center doing research, yes, do both. If you see yourself at a smaller community hospital doing rounding on pulmonary and covering the ICU and stuff, then yeah, do both. But it does say train for the job you want.
Thank you. We do have a question in the chat. We actually talked about it briefly. A resident is asking, how can a resident show interest while rotating in a critical care unit that has a fellowship program?
Certainly,
go ahead, Bob.
No, I was gonna say if you go to a program and so you show up as a visiting resident to do a rotation and you're there, it's basically like an audition rotation. That is a 30-day or 28-day interview. That's I tell people that it can be the best thing you can do because you can for one you're going to beat out everybody who's only going to interview via Zoom. At the same time, you can shoot yourself in the foot, because now I've got 28 days to kind of see you work, and if you don't mesh well with the team, all right, now I know that, so kind of the best things are the same as with any other rotation. Just show up on time, be interested, be yourself, be proactive, and just be normal. It's sad, but like that's the best kind of advice I got. But a lot of people show up and they just aren't. Like it becomes an awkward month. Just please just be yourself.
Yeah, and show interest. Take ownership of the patients. Read on what we're talking about. Ask questions if you genuinely want to know. If you start asking questions just to show that you know, that we can tell that.
Yeah, I think I try to tell now my juniors, maybe now a PGY3, to just relax, because we go into critical care rotations usually extra anxious, because this medicine is the same medicine, but these are sicker patients. So most residents will go in with a little bit of apprehension. And so people try to be the version that they think attendings want to see. So it's great to hear from you that just try to be normal, just relax and try to be yourself. I don't know if we have any more questions from the audience.
Actually, hi, yes. Thank you very much for your time, and I appreciate the information that you guys are sharing. As someone who's actually interested in going into the academic field, working with residents or fellows in the future, what difference in application preparation would you guys recommend for when I do apply to fellowship?
You want to do academics primarily? Go for it.
I want to be an academic attending. Like, I want to be a part of a teaching program and work with residents and fellows.
I don't think there's any preparation that you have to do beforehand. If you want to go into academics, probably knowing how academic centers work would be helpful. So I would probably apply more to academic centers if that's your goal. And sometimes they tend to keep their graduates, you know. Um, but I think you'll decide with time what you want to do. And if you already are interested in teaching residents and fellows, you can start by taking care of some of the conferences. You know, you can do things to train yourself to be a better teacher.
Interestingly, one of the questions actually I do ask during interviews is, are you interested in academics or clinical or research or administration? There is no right answer to that. But in general, if you see yourself doing academics, the biggest advice I give people early on is save every single PowerPoint that you do, and steal every PowerPoint that you can from your co-residents, so that when you're done, you have like a library of a bunch of topics. But then you want to develop a couple talks, a couple topics that you can just talk about on a minute's notice. If I said, Dr. Cearras, I need somebody to spend 30 minutes talking about something, he could just rattle off 4 or 5 different topics, so we'd have a choice. And that's the same. If I've got my 10 different things that I can just talk about at a moment's notice. And everybody in academics has those sorts of things, and they all tend to relate toward whatever your niche interest is. So during residency is a time to kind of think about what are those topics and what are those things, and develop them. Just you practice them on other residents, you practice them on the med students, so that when it's time, you can just, all right, give me the dry erase marker, let's go, and start drawing on the board, and you're ready to go with whatever topic it is.
Yeah, and I've had some fantastic mentors that told me, have the same topic and have different lengths already prepared. Have your 5-minute talk for the bedside. And be careful that you tell the trainee that you're teaching them, because sometimes they don't realize it. So make it clear, I'm going to talk about this now. So do your 5 minutes on the topic. Do your 15 minutes when you have some downtime. Get your whole presentation on the same topic. And yes, gravitate towards the things that you're interested in, or the things that you see all the time in your unit. We have liver failure, so we talk about that all the time. We talk about TEGs, we talk about hemorrhagic shock, we talk about all things related. So, and talk about things that are going to be high yield, that they're going to find interesting, that they're going to find helpful. And I think we have.
Great, thank you, guys.
I think we have some questions.
Yeah, from Dr. Fernandez.
Yeah, hi everyone. How's it going? So I have one quick question. I'm trying to kind of piggybacking on the previous question that we had about rotating in the ICU. So now with this model that we have, that we're doing the interviews online and the whole WebEx change that we have experienced, how does let's say an outside resident that's trying to apply to your fellowship, has the opportunity of getting to know you guys, and you guys getting to know them, and them being able to show the interest that they really want when it comes to applying to your fellowship program, if they're only interviewing online for, let's say, 10 minutes or 15 minutes?
If you figure out an answer to that, let me know. We've been struggling with that for years. I mean, people, the number of emails that I get from people being like, I've sent you an ERAS, an application through ERAS, but let me resend it to you to tell you how interested I am. I get it, you're interested, thank you, but or the number of people who send an email just telling me how much they really want to apply to my esteemed institution. That does not show interest, sorry. Especially because a lot of them tend to be form letters. I think certainly if there's 1 or 2 programs that the 2 that are at the top of your list, most places are going to have some kind of follow-on thing, either like, hey, we're going to have an optional day where you can kind of sit in on conference either electronically or in person, or hey, we're going to have a thing on Saturday, some Saturday, where you can come walk through the hospital. If it is at all possible, do those. That's where you kind of really show the program, all right, I'm interested. And you certainly can't do that for everybody. But even if you can't do it, program offers it and it's just a day that you're not able to. Reach out to the program and say, hey, I know those emails, the emails where, where someone specifically says, hey, I wanted to come to the in-person thing, but I just can't because I'm on night float and there's no way to change the coverage, But if there's a chance to kind of talk to people or something, whatever could do, I'd really love to kind of get a little more of a sense of your program. Those kind of emails after the application or the interviews have already happened, those do matter more.
Got it. Thank you.
And it can also help you if you think that you like the program, but you're not sure. It can help you weed out the ones that you don't really like, or maybe there was one that you were like on the fence when you applied, and then you do the interview and you're like, oh man, this looks great. Make sure it is what you are looking for. It goes both ways, like Bob was saying.
And if a program doesn't offer a second look, ask them if you can come. Ask them, like, hey, would I be able to, if your hospital's, 30-minute drive from my house, can I come by sometime and, would there be a way that maybe one of the current fellows would be able to show me around and stuff? If a program is really interested in you as an applicant, they'll find a way to make it happen because they want you to be interested in their place also. So.
Thank you
so
both.
much, everyone. And thank you everyone for your questions. I think it's great that we have interest. I think we have covered all the important bullet points that we wanted to talk about. And then I'll leave the floor to Dr. Isaiah.
Well, thank you, everybody. Really appreciate it. Bob, Dr. Cearras, it's really, really great to hear from your insight, your experience. I agree 100% actually as an educator myself as well with all the tips that you have actually given us. And actually, Dr. Cearras has been a mentor of mine as well in the critical care world, so I really miss those days sometimes. But in any case, then guys, please feel free to follow us in our social media accounts. Feel free to follow up in our Instagram, ACP Florida chapter. This webinar is going to be posted there, and just spread the voice. We're also then doing the fellowship webinars on cardiology, hemoc, GI. They are all happening this week from Monday to Thursday. And next month, by the way, in September, we're going to do the same for internal medicine residency applications for any friends who may be interested. And as to Dr. Bob's comment, the ACP does have chapters, committees, councils that you can be a part of. So, and we are for sure recruiting help. We need help. We need people who are engaged and motivated to help with networking and educational opportunities. So just feel free to reach out to myself if you want, or Nancy as well. And I'm going to leave my email over here in case anybody's interested in growing a little bit more into the Council of Residents or any other committees that the chapter has. It's luis.iciamercado.md@adventhealth.com. And, we can talk more about it. And actually, and when you go into your fellowship and then you become an attending, I will say you're still always going to be an internist, and ACP can always be a society to welcome you. And, we'll love to keep you as a member. Well, thank you, everybody. Appreciate it. Have a beautiful night.
Thank you, everyone. Thank you, Dr. Bob. Thank you, Dr. Cearras.
Thank you, everyone.
Bye. Thanks for having us.
Bye. Thank you so much, Hamza.
Thank you.
Thank you.
Bye.